Thank you. So it's an honor to introduce Dr. David Lamb, who is the Atwood Endowed Professor for Oral and Maxillofacial Surgery at the University of the Pacific Dental School. He's also the chair of the Department of Oral and Maxillofacial Surgery and Associate Dean for Medical Integration. Dr. Lamb earned both his DDS and PhD degrees from the University of Toronto, and went on to serve as a postdoctoral scholar and surgical fellow in maxillofacial oncology at UCSF. Dr. Lamb then earned his MD degree from UC Davis. So thank you, Dr. Lamb, for joining us.
Thank you for the invitation, and it's been a good afternoon talking to the best and brightest. The #1 department of oral laryngology head and neck surgery. It's an honor. So I'm going to give you an applause for that. Okay. So it's a pleasure to speak about this topic, and obviously the 45 minutes I'm allotted doesn't do justice, so I'm going to try to touch on some highlights. And thank you, Dr. Samu, for the kind introduction. So I'm a surgeon scientist, and my research and clinical programs are closely integrated. So really my research focuses on the problems I see in my patients every day. And one of them is the oral cancer patient. So really, since we're in San Francisco, I really think about this as ideal patient care is really bridging the continuum where, you know, it's not only diagnosis but prevention to be at the far end, in management and treatment, but also long-term care and follow-up and management of complications. So I think, and I thank Dr. Samu for this invitation, I think working together with dental and medicine, we can really bridge that gap to give the patient the best continuity of care, really from prevention to functional rehabilitation. So I'm going to be talking on those aspects today. So this, as you all know well, 30,000 new cases of oral pharyngeal cancer, 8,000 deaths yearly, more than melanoma and cervical cancer. Despite all the innovations, really the 5-year survival rate remains unchanged. We have amazing innovations in reconstructions, and patients are doing better, but the survival rate hasn't changed. So really, the obvious thing is early detection and prevention improves survival. So I think this is an interesting study way back, but I think it still holds true today. And you don't have to really look at the fine print, but I just want to point to you, this is the clinical stage of oral cancer in a general dentist's office at the time of diagnosis. And the blue and the green is early stage, or stage 1 and stage 2. So I want you to look at that piece of the pie, okay? And I want to contrast that with in medical primary care offices. You can see that early stage pie is shrunk significantly in its late stage, right? So this tells us a couple things, right? Dentists are trained very well to look at that. They have that focus. Often patients see dentists more regularly than their primary care doctor, so we're at the forefront of kind of gatekeepers for managing that. There are some very good primary care doctors who do a good oral exam, but sometimes their bandwidth and all the other complaints limits them. Some schools don't have the experience to look in the oral cavity. So there's multiple reasons. So from an education standpoint, it's a very important thing. So when you think about it, putting the two groups together to share the strengths in education is an important thing to think about. So part of it, what's the difficulty with screening? So the classic things we learn, ulceration, fixation, nodularity, those are really characteristics of advanced cancers. The precancerous and very early stage microinvasive cancers often appear identical to benign-looking lesions. There's really no distinct features. This is a group of patients. When I was at UCSF, we had this dysplasia clinic, and if you look at the column on the left, you have a lateral tongue lesion, flora mouth, and buccal mucosa. Those are dysplasias. You look at the column on the right, those are squamous cell carcinomas. You can see clinically, it's hard to distinguish. So one thing I noticed in this dysplasia clinic at UCSF was we'd have these patients, depending on mild, moderate, severe, we'd either monitor short-term, long-term, monthly, or 3 months, 6 months, or annually. But I always told patients, if something didn't feel right, come see me sooner. And what I noticed is when patients reported pain, something just didn't feel right, something was tingling, more sensitive, they come to clinic, we do a biopsy, it becomes cancer. So pain is a heralding sign. And look here, this is your normal mucosa. This is carcinoma in situ, severe dysplasia. And really, you see all these dysplastic cells, it doesn't become cancer until one of these funky cells goes through the basement membrane, right? To become invasive cancer. So the thought is, why is it's not painful when you still have the same types of cells here, but when it goes through, it starts causing pain? So we did a questionnaire, and you can see, and it may seem obvious to you, but your normal patients don't have much pain. Your dysplasias don't either, but your cancer patients, they have spontaneous intensity, sharpness, aching, and sensitivity to touch, but it's really under function when they start eating, chewing, speaking, that the pain is really hurt. It's a mechanical pain.
Why are actus ulcers so painful when they're so superficial?
It's a good question. I think it's an inflammatory reaction that causes it, right? But it can also be secondarily infected, and we do see probably over 90% is a secondary candida infection, so it could be that. So with cancer, in head and neck cancer, over a third of head and neck cancer patients have severe pain, and it's significant. Other than prostate, it's one of the most severe pains. Your breast and melanomas, unless they metastasize, you don't have the amount of pain. So, the cancer pain world, we identify lots of markers and in the lab animal models, but you can see from successful identifying, it dwindles. My target candidate safety, your phase 1 safety is usually good. It fails when you test for efficacy in the patient. Why is that? So part of I just want to check with the Zoom people. When I wander, do you still hear me? Maybe they don't hear me at all.
Yes.
You can hear me. Okay, good. If you didn't, I was going to say I was very witty. The part you didn't hear. Okay. So part of my interest has been in looking at developing novel preclinical models of cancer pain. And part of it is, obviously, head and neck cancer, does not present as pain in the foot, right? So why is it that all the preclinical studies in pain, they look at fall withdrawal, temperature sensitivity, and you'll see the bulk of papers, you'll see it's highly successful. You give them this agent, it will reverse their pain from pinching their foot, right? Heating, all these things, right? Very convincing. When it fails in the clinical environment is because the animal model doesn't recapitulate what the real disorder is. So we sought out, and this is early on, when I was at UCSF, and Dr. Liu knows this well, and the players involved, but we developed this dolanometer, and dolor, it means pain, noa means chewing, meter means measurement, right? And John Dolan, very, very brilliant guy, he called it that. He said dolor for pain, but I really think he tried to name it after himself. Is what it is. But
Looks like baloney.
But let me just show you how it works. I can get it to work. Yeah. Okay. Unfortunately, the video is not working. But this is a device that fits in the mouse cage, and there's a tube, and the way you put the mouse in the tube, and if it can traverse the tube, this is where the food and water and bedding is. You put it in, there's 2 gates here. When they go in, it's a tube that's narrow that it can't turn around. So when it's based on a mouse or a rodent, when they're trapped, they naturally want to chew through. So they chew through the first dowel, it starts the clock, and when they chew through the second, the time stops. So we tested this in multiple strains of mice, and pretty much after all strains of mice, over 20, they predictably after 10 trials can have a good baseline. Then you can test their function with any test. If you grow a tumor, how it impairs it. If you give an analgesic, does it reverse it? So this is a picture when I'm sure, because I'm on this default display, I can't play it, I apologize, but it's just showing infrared camera what the mouse does to knock through the dowel. And it doesn't swallow it, it just eats the pieces up. So in preliminary studies, we see when we inoculate squamous cell carcinoma line in nude mice, they grow tumors in the floor of the mouth, and they end up, the baseline chewing, they end up over days as the tumor grows, not being able to knock through. The control can continue. And because,
I have,
yes.
sorry. I have a question in the chat here from Jennifer Lee. She asked, would you biopsy even if there is nothing visible if a patient can localize a site of pain?
It's a good question. I think it's history and patient specific and risk factors, but I will be going on to some agents that can, adjunctive agents that can help you better identify the lesion if you can't see it. So hold that thought for now. It's a great question. I feel like I'm speaking to God or something. All right, and then here is the only real agent we know for like severe head and neck cancer is morphine. So you can see when the tumors grow, the in black, the pre and post when you get morphine.
I mean, let's.
Hello? Okay. The morphine attenuates it, and their baseline they can chew better and get through that down. The reason we see why we gave a morphine vehicle is just the rather why we gave the naive mice morphine here. It makes clinical sense. If you give morphine to a naive mouse, it's sedating, it'll impair the chewing. But in the literature, there is evidence in rodents, if you give mice morphine, it gives them a gnawing habit, a tick that makes someone argue maybe it makes them chew quicker. So we wanted to prove it was an analgesic effect and not a morphine non-specific activation of a muscular habit. Okay, so we had a device that was predictable, an operant device that could objectively, we put the mouse in at night when they're awake, they gnaw through, in the morning we get the measurement. We can test anything very objectively. So just looking at this clinical picture and going on with the dysplasia is you go through the normal stages of normal mucosa, your mild, moderate, severe dysplasia, carcinoma in situ, and your invasive cancer. The thought is, there's a whole bunch of mechanisms we learn, but for that invasion, oftentimes it's matrix metalloproteases and other proteases that are released that facilitate it to go through. We've looked at matrix metalloproteases as important in the carcinogenesis process, but really for cancer pain doesn't play a role. It plays a role in other types of pain like temporomandibular joint. But there's a novel protease PAR2 receptor that's found on sensory neurons that we showed a novel pathway that PAR2 plays a role. The cancer cell releases serine proteases and other proteases that activate this PAR2 receptor. And we demonstrated this in both acute and chronic pain models to show that. So my mentor Brian Schmidt is continuing that work and looking at targeting it better at NYU right now. Okay, so to go on the question about some adjunctive aids, so if you had someone who had a known history of dysplasia or cancer, high risk factors, even if you don't see the lesion, some of you may know toluidine blue, OBGYN, and other people use it, but it's a vital dye, stains nuclear material, preferentially stains high rates of cell turnover such as neoplastic mucosa. And the staining dark blue is positive because the dye really binds to the nuclear material, so it's not a superficial stain. You wash the toluidine blue away and it intrinsically stains the DNA. A pale blue is more representative of benign lesion, so there's no nuclear stain. In the mouth, just to be aware that the papilla of the dorsal tongue also tends to retain the blue. but we're lucky the dorsal tongue really isn't the main site. The lateral tongue and ventral tongue is really where our cancers are. So I just want to point, this is an adjunctive aid. I don't use this regularly. When I see an obvious lesion, we biopsy, we don't need this. But in a person with large field dysplasia, you're trying to find the best area to biopsy, it's very helpful. And also in the OR to make sure I remove it all. So the top panel you can see, you just applied the toluidine blue, and then you wash it away. And on the bottom panel, you can see where you washed it away, where the original huge hyperkeratotic lesion was, right? So if you're deciding where to biopsy it, you have that whole area. You can see the false positive dorsal of the tongue is staining, but the one dark area is the area you want to excise or biopsy. So it's very helpful with that. So just to show you here, it's a less subtle, a more subtle lesion. You stain it and it becomes much more obvious. Okay. Some people don't like this because it's messy. If you read the original books, they tell the patient to swish and the patient coughs it all over the place and people don't like it. I just take a cotton swab and I paint it. Right? The key is you use acetic acid to paint it first to get rid of the overlying salivary proteins and things like that. If you don't have it, I usually just tell my resident go to the cafeteria to get vinegar and we paint it on, and then we do that. Okay. The other thing is, and this is again from the OBGYN, there's a bell scope. Put your hands up if you are aware of what bell scope is or heard about it, or if anyone's asked. I have no doubt that Dr. Samu does. So I'm Canadian. It was discovered in UBC when I was a resident. They were begging for us to test it in the mid-2000s, early 2000s. I had like 10 of them. And we thought at the end of the day they're useless because we know what we can see in the biopsy. So again, it's not to help you decide the biopsy, it's when you've already decided the biopsy to choose the best area. So autofluorescence, intrinsic, when cells absorb light, when they fall back, they release an excitation. Each cell has different autofluorescence. Okay. The big thing, erythrocytes can lead to a false positive because inflamed site can cause that also. Okay. So cancer cells have different emission patterns. So this is the original iteration. The newest one is very, very small. You can connect an iPhone to it, and the iPhone can take pictures, store it, you can name it. So it's much smaller than this. But it shines a high intensity blue light, about 440 nanometers into the oral cavity. So just to show you, normal tissue should autofluoresce green. Bright is hyperkeratotic lesions. Dark is malignant or dysplastic. Okay. So again, the false positives, the attached mucosa, gingiva, and tonsillar colors are typically darker. Malignant lesions or dysplastic lesions are much darker. Okay. And again, the erythrocytes, inflamed tissues can be a false positive, but if you apply pressure and blanch it, it gets rid of that blood flow. It should be normal. Okay, so again, adjunctive aid, I'm just going to show you, this is how it works. The blue light, autoreflection. The abnormal cells will disrupt that autofluorescent pattern. So it'll be dark. So again, normal mucosa, that's how it should appear. Here's a severe dysplasia lesion, not so obvious maybe. And you can see it's much more demarcated, sharper lines to outline. Okay, so that, I use it as a teaching aid sometimes. I don't rely on it often, but I thought what's interesting is taking advantage of this autofluorescence. You don't have to add any, dyes or agents. It's a very easy handheld thing. The only problem is if you forgot to charge it. But also, it works very well for differentiating vital bone and necrotic bone. So for medication-related osteonecrosis of the jaw, osteomyelitis, ORM, from margins, it can be helpful. So just to show you here, this is a MRONJ patient. You can see bone exposure in the oral cavity. CT shows sequestrum out of the bone there. You can see clinically what that bone looks like. It's pretty obvious where the sequestrum is, right? So removing, what's remaining is you want to see normal fluorescent green bone for your margin. And so it's been helpful for that. Okay. All right, so I'm going to move on. Another area for craniofacial defects, obviously the topic is malignancy, but trauma and other problems can have defects in bone. For retromolar squamous cell carcinoma, we've gotten very good using virtual surgical planning to outline the agent. We can take a CT of the fibula, do it all virtually, plan it, have our cutting guides, and this cuts down time significantly and makes it much more predictable. Now we have titanium cutting guides that are even less bulky, that works very, very well. We can simulate our surgery, have our cutting guides. Here's just an example of it. Cutting the mouth. And you can see these original polyurethane guides are a lot bulkier. The fibula is not much of an issue, but in the head and neck area, you often have to raise the flap significantly more to fit the guide in. But the titanium guides are very thin now. And we can also have the custom plate, so we can have everything shaped at the leg beforehand. Have it inset. And if we talk about full functional rehabilitation with the same virtual planning, we can also make the cutting guides that have the implants placed at the fibula while the blade of surgeon's at the top doing the resection. We can have all the implants placed. When we bring it up together for the anastomosis, we can get the maxillofacial prosthodontist to actually put the teeth in. So this is the jaw in the day feature. Just as an aside, obviously you might hear these cases are very expensive, and it's true for like the private practice cases, but there are CPT codes that will cover the implant fixtures. There are CPT codes that cover the denture prosthesis if it's removable. If it's fixed, it's not covered. So as an academic surgeon, you take it, that's why you guys will, if you're in private, will have a nicer cars than us, but we do it to help the patient. So I want you to be aware that it's not a fortune to do. Some of us are willing to do it at the reimbursed costs of Medicare and Medicaid. So it's important for the patient. So just want you to be aware of that. Now, this is the dream all in one day. You don't have to do that. At the very least, it's usually wise to put the implants in, because the big thing is half the time you might say, oh, I can delay the implants, thinking you don't need to give radiation, but surprise, surprise, your final path, you need to, and then it becomes a nightmare. You radiate, or you stall the radiation to put in the implants. It's a problem, right? So doing it at the time, you'll never regret it, other than taking a little bit of extra time to put it in. But like I said, if it's a two-team approach, it doesn't really add much more time. Okay, so that is our vascularized flaps. There's always a need for other bone scaffolds and needs, and that's an area of interest of mine. You can see the issues with autografts and donor site morbidity, increased off-coverage of time. You're all familiar with that. So the goal is to develop novel scaffolds that you don't need donor site morbidity. Okay, so we're just completing this SBIR fast track grant with very promising data. This is a new crest scaffold, and I have no financial interests or disclosures on this. I did this purely as a scientist to prove it worked. I wish I had some interest in it now, but I don't. Okay, so it's a 3D scaffold, hydroxyapatite, polyurethane, xenographite particles. What's great about it is they can tune the porosity. So in the craniofacial complex, to match the craniofacial bone. It kind of acts like, I don't know if you've used gel foam, but when it rapidly absorbs blood and it expands about 15%, so it actually kind of fixes into the defect in the nooks and crannies. Handles very well. You can carve it with a scalpel or scissors. So that's kind of what it looks like. Okay, and it rapidly absorbs blood. So we tested this in a Calvario model, critical size defect in the rabbit model. You can see up here, this is a new crest. It rapidly absorbs the blood. This is a xenograph bone. You can see it states that it doesn't absorb the blood. Because it expands and fits in the defect, it holds in that. We didn't need a membrane to secure it like a xenograft. And you can see over time, at 60 days, the new crest significantly has enhanced bone formation, micro CT. but also in histology. And on the bottom panel, this is a trichrome stain. So the dark red and the blue is new bone formation. So we moved this study. It was a very ambitious study. We tested it as proof of principle in the calvarium model. Then we did it in a sinus model, which was successful with dental extraction model. And we're finishing up a 3 centimeter mandibulectomy model. And the preliminary results are quite encouraging. The question is, and I'm trying to convince them, but they won't fund it, is the market's too small, is if you radiate the tissue bed or you radiate the graft, what would happen? So I'm begging them. I think I might have some buy-in down the line to do it, but that's $1 million question. We'll do it.
So in that picture, you didn't plate, it wasn't part of the plating.
No, yeah, so you can see, so this is the empty control, doesn't heal. This is an autograft, the area we segmented, we put back. You need screws fixation. But this, it just expands and fits. My colleague was like, no, we gotta put in a screw, but I wanted to prove that we didn't need it. We didn't need it. There was no loss of venus. Okay, so bone sets the tone, and then there's soft tissue issues, right? And nerve and sensory function. So classically, we want to cure the patient, we remove the tumor, restore continuity. It's often at the sacrifice of sensation. Sometimes with the flaps, we can try to graft the nerve, but I'm just going to show. So in the old days, and this is not a cancer, but this is from a third molar injury. It used to be you rob Peter to pay Paul, right? You lose sensation in the lower lip and chin from injury to the inferior alveolar. I would say, would you rather be numb in the earlobe or the side of the foot, right? Here, we'd have to take the greater auricular nerve to do it, but there's a size mismatch, so we'd have to do a cable graft to do it. So this was the old days of doing it, where we exposed the injured nerve, resected the healthy margins. You can see the greater auricular mismatch in size, so we have to do a cable. Patients did well, but it came at a price, right? They were numb and durable. So really, since for me, it was about 2012 when I started using these. And if you're not familiar with it, it's the only FDA-approved allogeneic nerve graft, and it's from cadavers, both sensory and motor. It doesn't matter. Frozen. You can basically just ask, like a catalog. I want a 3 millimeter by 50 millimeter nerve. You thaw it with room temperature saline, like this. Pliable has the outer epineurum. So this is just an example early on of my using it. Right lingual nerve injury, completely anesthetic. This is from an orthodontic surgery. Not from Dr. Liu, because Dr. Liu's amazing, he would never do that. But originally, they used bicortical screws. And one of the screws hit the nerve. The surgeon promptly removed it, tried to put in a plate, but the sensation was never returned. So we exposed it on the lingual. You can see this is the area where the screw and oxygen nerve there, and full restoration of sensation. Okay. So getting to the tumors, in cancer, it's do we graft an ablative defect or not? And obviously, there was always this with donor nerve critical size. People were never confident, after 2 centimeters, let alone 5. But now we've gone up to 7 centimeters, pretty much the length of a mandibulectomy, with success. And surprisingly, when you do a primary resection, patients recover very predictably if you do the nerve. It's very different from a traumatic injury where the prognosis is weird, there's more inflammation, the mechanism of injury. A clean cut of the nerve with an ablation, patients do very, very well. So this is just an example of a resection. Obviously, it involves the inferior alveolar nerve, and we use an oxygen nerve graft reconstruction. Okay. And this is just a paper that showed that up to 7 centimeter defect you have success with. right? And this is an example of an ulcerative necrosis patient. We did virtual planning for it. All the cutting guides, custom plate, and we also got resected. So before inside of the fibula, we do the nerve. And sometimes the proximal end of the nerve is way back up near the skull base. So this parachute technique is very, very helpful. You use this protector. So the thought is when you do a primary neuropathy, you can have some tension right at the junction of where it's critical for it to heal, where you have kind of a misalignment of the axons, which can take longer. So using this coupler, you bring them close enough so they can find their own way, and you take the tension away from the primary to put it away. But this parachute technique makes it easier with closer skull base surgery. This is just an example. And you can do this at the table. You can put the connectors on both ends while they're still doing the ablation, and then it just it takes minutes to bring it up and inside it. So inferior alveolar nerve, lingual nerve, very good. The question was the infraorbital nerve with maxillectomy. And this is just an example I'll show. This is a woman who presented to, while I was in New York, Stony Brook ED, dental resident saw. She complained about ill-fitting denture. The dental resident unfortunately called this irritation from the denture. But you can see all this is normal mucosa. This is a residents who were talking, right? This is a submucosal mass. There's no surface. The surface tissue looks pretty the same. It's erythematous, right? There's some vascular aphasia, but it's a submucosal mass, right? So thank goodness the patient presented again within a week, and we took an X-ray. It's a Panorex, maxilla, and I know you guys, but you can see this is the normal side, your sinus remaining bone, right? You can see this in a morphine bone, so there's a tumor here, and the sinus is obliterated. You can see on CT, so you can see it's encroaching the ethmoid sinus, the oral floor, the nasal cavity, obliterates the whole sinus. So we had mixed, we did 2 biopsies. It was mixed ameloblastoma versus malignant version of ameloblastoma. Wasn't clear. We treated it, the margins were the same. We did a whole PET scan. There was no lymphadenopathy or other signs. So we planned this, again, with virtual planning. We had our cutting guides made for the resection. That's the planned margins. And we actually used a custom MedPore implant there, which, to date is really good for reconstructing the oral floor, and a portion of the zygoma has never been really extended to allow rim or the alveolar bone structure. But this worked very well for her. So I'll just walk you through this. So we approached it, did the resection. The difficulty was at the level of the pterygoid plates to get that. Resected it. That's where the one cutting guide is on the alveolar portion. The other arrow shows the cutting guide at the lower rim, and then the other one's at the zygoma level. So that's where our cuts are planned. You can see where we down fractured the tumor, the inferior orbital fissures there, orbital floor, the turbinates, the alveolar ridge, the frontal process. So that's the final specimen. And reconstructing this, the big thing with a maxillectomy defect, whether you put bone or implant, it's really a secondary infection, right? And it's often from the nasal cavity. So we took a nasal septal mucosa flap to close that end of it. So we rotated that. And to close the palatal aspect, we did a temporalis flap. Okay, so this is, you tuck it under and through. And with the defect there, we did a temple implant, and in a woman it's much more obvious when you do a full thickness. And because it violated the nasolacrimal duct, we did a deprocystolinostomy there. So, you know, this is pretty straightforward, but what I wanted to show you was with MedCore, it's good. You can punch a hole in there, and from the proximal segment of the remaining infallible nerve, I grafted axogen nerve to it, and I tagged where it inserted. This is just suturing the nasal rib to the implant. And the temporalis flap, sealing it. So that's for immediately post-op on the far right. This is 5 hours post-op in on the floor. And this is about 2 weeks, and you can see the temporalis flap has reclosalized. So this does very well. She has the left remaining hemimaxilla that could see the denture, but she wasn't happy with this. So the other option which we do is zygomatic implants, and often now what I do is at the time of ablation I put in these implants. Again, there's a CPT code for it, it's covered, but it's, you know, it could be a sleeper if the patient doesn't want to use it, but it's always good if the obturator they're unhappy with or there's problems on the line, you have it. And if they need radiation, it's not an issue. It will have osseointegrated by the time they recover from surgery and start radiation. So that, my take-home message is, if you think there's a chance that the patient will either want it or need it for stability, retention, or full functional rehabilitation, the time to do it is at the time of ablation for the implants. And this is just another example of how you would do it for basically a total maxillectomy defect. Quad zygomas, 2 on each side, that gives you the stability, 2 in the anterior part, 2 in the front. Okay. So, any questions about what I've talked about so far? Okay, so just a couple thoughts on the future. So, I told you the axogen nerve graft is the only one that's FDA approved. But, you know, some people have issues with cadaveric things and infections and doing it. So we are working, I'm working with my collaborators at University of Arkansas. We have very promising results of a nerve conduit, and we've exceeded that kind of 1 to 2 centimeter critical size. We've had success at 4 and 5 centimeters now with regenerating the nerve. This is purely on a histology. We haven't assessed function yet, so we're doing that next. And then in the head and neck area, the ideal situation is, this is a new press, and that's a conduit that you would have the nerve in the bone, like the mandibles, and you can inside it up at the time of surgery. And the thought is, what we're trying to develop, that this is kind of expandable, that it can kind of stretch and fit on the nerve without tension, that you don't even have to do sutures, that it will just, you can put in your proximal and distal ends of the nerve in that area, and it'll recapitulate. So one obvious question we thought a reviewer might ask is, we say this expands 15%, how do you know if it will close your lumen, prevent that? So we did a study with that, and showed that the lumen stays open. So stay tuned, and again, I have no disclosures or financial interests, fortunately or unfortunately, in that, but I think there's some promise in there. All right, I don't know if I'm on time, late, or early, but I thank everyone for their attention, and if there's any questions, I'm happy to answer. Are Zoom friends on?
David, that was really terrific. Thank you. I'm Lisa Liloff, and I really enjoyed the whole spectrum of your talk. And just going back to the beginning, I just have a couple of questions. If you have thoughts about just the dichotomy of medical insurance and dental insurance, and the fact that these are all part of healthcare, but a lot of people don't have dental coverage, and you know, it's probably not the person who goes twice a year to get their teeth cleaned that gets, you know, the advanced stage cancer. It's the one who doesn't present until they have the pain. Is there any way we can ever reunite medicine with dentistry, at least in terms of universal coverage?
Yeah, no, it's a great question, and yeah, you're speaking the truth of it. It's unfortunately, there's special interest in other challenges where, so the academic dentists want that, and we're working, and we're getting closer with certain things. We're getting some wins now. The reimbursement in the OR used to be that 499 code used to be $219, so a hospital would never do it. They raised it to, the proposal on the floor is to raise it to $3,000 now, so at least the hospital is going to do a little bit better to get the dental care needs in. The problem is, in North America, what separates us from NHS in England is the dentists and a lot of other, they like to be independent and they don't want to be dictated fees and prices and things in the end. I think at the end they want to help, but it's not at a cost that they can't survive or run the process. So there's that piece. So I think if we get to a level of better reimbursement, to at least cover overhead, is the challenge. I think in California with the Denti-Cal, which is the dental part of Medi-Cal, it's actually shockingly good here. It's better than a lot of private insurance plans. So the patients who are on that qualify for a lot. We can do a lot for preventive care and actual care. It covers, just an example, wisdom teeth and full general anesthetic, it's covered for them. A lot of dental private plans don't do that. And any pathology, it's all covered, and we don't need like a pre-op for it. So I think New York and California are better for that, but it's only that income bracket, right? So everyone else, sink or swim, whatever. So it is, I think we're getting closer to try to get there, but just like anything, universal healthcare has its proponents and other things. But it is a good question, and it's something John and I are looking at to see how we can, support each other, Pacific and Stanford, in that realm, right? To complement each other and do those things. So it's a great question, and hopefully stay tuned, and we have your support. We can get there. Thank you.
Great.
Yeah, I think along those same lines, we do a lot of reconstructive surgery for mandibles, and I'd say less than 10%, will get the final restoration of their teeth. And, I guess one question I have is, what sort of incentives do you think we can give to prosthodontists, who are in the community to work with us? And then the second question is, I've heard that the market for prosthodontists is, that most prosthodontists who were working with academia are kind of aging out, and so what do you see as the future for that?
Yeah, it's something we're facing at UOP. So we are actively recruiting 2 maxillofacial prosthodontists, a senior and a junior one. We actually have a few good candidates. The problem is retaining. So there is recruiting, which certain schools can from the outset. I think UOP is pretty good at that, at recruiting. Other schools, salary and other things get in the way. Retaining is another thing. So history-wise, they see the grass is greener in the private practice and financially. So I think supporting them. So the ones where there isn't strong residency. So as you can imagine, just like doing head and neck ablative on Baltimore, if you don't, it's harder for the solo private practice doing it all, taking the call separate from an academic when there's residents, staff to support, right? So it's not enough for us to recruit just a maxillofacial prosthodontist and expect them to be available 24/7. We have to, have support for a residency program and other people to help that, and then that takes a load off. So I think that makes a big difference. And if you look at other things, a lot of programs of prosthodontic residency, they don't even rotate or work with the maxillofacial prosthodontist. That's like an elective. I think making it a requirement to support it is a helpful thing. So for us, I think at the current time, you really, for all patients, academic prosthodontist is the one you want to work with. You might have the odd one that's altruistic that will help, and finding those are good too. And they might do a certain number of cases, the altruistic.
Yeah.
Hi, that was great. I'm Dimitri Police, I'm a medical knowledge. I have a question about nerve regrowth and engraftment. So I'm thinking about a nerve as a kind of a telephone cable, and you just lopped out an inch segment. And
I like to say surgically excised as opposed to lock. But that's
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 true.
what we do.
Lately I poison, so you guys lock out. You're putting a conduit in there, so it's like, of all the different fibers, how do they find the right partner, or is the actual mapping different? Does the patient afterwards say, oh yeah, when you touch here, that's in back of here, and it's flipped around, and how does that actually play out?
No, and it's a great question, and that's been the challenge for neuroregeneration. So the critical size in general for a conduit, so whether it's like a vein or collagen or whatever you use, it's about a centimeter. You can't get success beyond a centimeter, and it's variable what success is with a centimeter because you are relying it to cross that gap, right? And it's usually a millimeter per day, and 10 days on each side of a defect. So you're looking at with 1 centimeter defect, you're looking at about 30 days for it to cross that gap to get initial sensation. 10 days to cross the gap, millimeter a day per millimeter, and 10 days to do that, right? So you're relying on the actual living nerves on the proximal segment, the neurotrophic factors from the native tissue it's innervating, and what's left of that nerve that's there.
No,
So
but I mean,
the
of all
signal-
those
so-
separate fibers, do they ever line up incorrectly?
For a sensory nerve, you get a motor nerve, it's challenging, if at all, right? So that's why we will never, up until now, we never beyond a centimeter do use a conduit. The axogen nerve is very different. Cadaveric nerve, it has a structure, right? It has epineurum, has that structure for the cells to follow along. There's a scaffold for it to go, not as opposed to an empty tube.
Yeah.
The study people have tried, they've tried to have liquids and fluids and things in the middle and stem cells, but if you mess with stem cells, you'll never get it to market, right? Like, it'll work and look amazingly convincing, but if you want to really translate and get to market, you have to stay away from those things. So we've had with that too, and I didn't describe it, what we found, which is very, very different. So the new crest, I'm going to go back to it, it's nanoparticles. So if you think about it, what it is, it's xenograft bone particles, which is not osteoinductive. Polyurethane is not osteoinductive. Hydroxyapatite, those are the 3 ingredients, not osteoinductive. You take that new crest, you put it in a muscle pouch of a mouse, which is a model for osteoinduction, because there's nothing else that can form bone in there, right? It forms bone. So it takes stem cells, native stem cells, which by definition is osteoinductive. So we don't know the exact mechanism. Is it the increased porosity, vascularity that allows stem cells to go through, or the thought more so is nanoparticles can stimulate the osteoinductive. And we're seeing that with the nerve too. It's a nanoparticle proprietary thing they have going, which they won't even let me know. It's this nanoparticle that they believe is guiding, doing something. I didn't believe it until I saw the data, but it doesn't make sense to me from what we know of conduits thus far that have failed over and over to have a nerve. So they've gone to almost 5, it's like 4 and a bit centimeter. You look at it, serial section of the histology, it looks like a beautiful nerve. So the question is, are they functioning? So we don't know that yet.
Dave, is there anything that actually works on severe dysplasia, like chemopreventive, and is there anything new on the horizon for that?
Unfortunately, no. Like things are really like case-based reports, and nothing that's convincing enough that we would use safely, to my knowledge. So, but there's a lot that's worth trialing, doing, but nothing that I take to clinic now. So really, it's surgical resection, or you have to think about the morbidity of doing it versus not, and as you know, right? So it's tough.
So you just kind of follow them for life? Is that how it works?
And really, if there's an obvious change, or we weigh the risk versus the benefits of doing it.
Does acetic acid really hurt when you paint it on?
No, surprisingly, no. They've never complained or winced? No?
think
You
it
would think. It's so low though, I think like the vinegar, because if you think about it, you know, you're having vinegar on your fry. Well, I'm Canadian, so we have vinegar on fries. I don't think. Is that weird? Yeah, but in chips, right? Yeah. Yeah.
Actually, Chris Holzinger, he uses acetic acid intraoperatively,
Uh-huh.
you know, to look at leukoplakia dysplasia by itself without the toluene blue. It seems like it works. I haven't adopted it, but
The patient's asleep then, so they
they're
can't
asleep,
complain.
so it
They
doesn't
just
really
look at it.
matter.
Yeah.
Anything else? You guys still look awake, so I think I didn't do my job. I didn't put you to sleep.
Yeah.
But thank you for your interest. It was an honor being here.